Welcome everyone. In this video we shall be talking about perianal sinus and fistula and discuss all the questions related to it. So moving on to the first question. The most common cause of fistula in ano. Fistula in ano is nothing but a different name for perianal fistula. Okay. What is the most common cause? All the given options are causes of perianal fistula, but the most common cause is cryptoglandular infection. Okay. Now this accounts for around 90% of all the causes, and remember that it is almost always associated with perianal abscess. It is almost always associated with perianal abscess if it progresses to fistula. Okay. Moving on to the next question. A patient has intermittent purulent discharge with a sinus near the perineum, but no internal opening on endoscopy. What is the most likely diagnosis? Now over here, the most important thing that we need to know is the basic difference between a sinus and a fistula. Right, a sinus is just an opening in the exterior but no opening in the but no internal opening. Okay, no opening on the interior aspect. Okay, whereas fistula has both an opening in the exterior as well as interior aspect. Internal opening will be present in a fistula but absent in a sinus. Over here the question mentions about no internal opening, so over here the answer directly becomes perianal sinus. Simple fistula, again fistula, high fistula, extrasphincteric fistula, all other three are fistulas, right? So over here answer would be B. Okay. Moving on to the next question. Which of the following characteristics classify the patient's fistula as complex fistula in ano? Okay. Now before moving on to the options, let's quickly have a look into the basic difference between simple and complex fistula. Right. Simple fistula, remember that there is low involvement. There is low involvement, low perianal involvement. Low perianal fistulas are usually simple, whereas high involvement is seen in complex fistulas. Right. If we talk about the tract, it will be a single and a straight tract, in simple fistula, whereas we get multiple or branched tracts in complex fistula. Simple fistulas, the one that fall under simple fistulas are low transsphincteric and intersphincteric my bad. Right, we shall be talking about these types of fistula. We shall be talking about these types of fistula a bit later, right, under Park's classification. Now the timing, just remember that low transsphincteric and intersphincteric are the ones that belong to simple fistula, whereas almost all other belong to complex fistula. And remember another fact, that simple fistulas are associated with perianal abscess, whereas they are associated with systemic diseases, whereas complex ones are associated with systemic diseases. Now let's have a look into the options. High transsphincteric will be a feature of complex fistula in ano. Okay. Suprasphincteric, again suprasphincteric is also a high involvement. Extrasphincteric is also again high involvement, and fistula associated with Crohn's disease, again a systemic involvement, so it will be also an example for complex fistula. So here answer would be D. Okay. Moving on to the next question. Identify the correct match as per Park's classification. Now before we identify them, let's quickly have a look into the anatomy. This over here represents our external sphincter. This over here represents our internal sphincter. This is our dentate line. And this is our levator and eye muscle. Okay. The basic anatomy is clear. Now let's talk about these. Number A, over here we can see that the fistulous tract passes through both the sphincters. It passes through the external and the internal sphincter and pierces only the internal sphincter. So this is a characteristic of intersphincteric fistula. Okay. Whereas it passes between the two sphincters but pierces only one, that is the internal one. If we talk about B, we can see this is also a low-lying sphincter. Low-lying fistula, and it pierces both external and the internal sphincter. So this is our transsphincteric. My bad, transsphincteric. Okay. If we talk about option C, we can very well appreciate the fistula crosses or pierces the levator and eye muscle, then it arches back. This arch is actually known as horseshoe. This arch is actually known as horseshoe. It horseshoes back and opens at the level of dentate line, right? So this is known as our suprasphincteric fistula, right? So all of these three opens at the level of dentate line, right? But if we see a fistula which pierces the levator ani but opens at a level above the dentate line, then we call it extrasphincteric fistula. This is our Parkes classification, right? And one extra point that we can remember over here, that extrasphincteric is almost always due to a secondary cause. Okay. Now let's have a look, right? Correct match. A intersphincteric, yes, A is intersphincteric. B is extrasphincteric, no, B is transsphincteric, B is incorrect. C is suprasphincteric, yes, that's true. And D is transsphincteric, that's false, D is extrasphincteric. So over here answer would be A and C. Okay. This is the most important question of this chapter, right? Identification of the different types, right? The Parkes classification. Moving on to the next question. Which indicates an internal opening of an anal fistula is located posteriorly, right? Let's have a look into the options. Circumferential pain. Now, circumferential pain is an extremely non-specific clinical feature which can be seen in any kind of anal fistula, right? It does not indicate that the internal opening is present posteriorly. Now, Goodsall's rule, exception zone. Let's quickly have a look into the Goodsall's rule. What does Goodsall's rule states? If this is our anal verge, right, we shall be dividing it into two aspects, the anterior aspect and the posterior aspect. So as per Goodsall's rule, if the external opening is within 3 centimeters, in the anterior region, then as per the rule it will open directly into it will open in a straight line, it will open radially into the anal verge, in the anterior aspect. The second point that it mentions, that if the external opening lies in the posterior part, it will follow a curvilinear path to open at the 6 o'clock position or the midline posterior position, wherever in the posterior line. It doesn't matter whether it is within 3 centimeters or beyond 3 centimeters. Okay. Another important point regarding Goodsall's rule is that if it lies beyond 3 centimeters in the anterior region, then it will follow the posterior path. That it will follow a curvilinear path and open into the posterior 6 o'clock position. Okay. Now, talking about the option, the exception zone. What is the exception zone? Right, the exception zone is this zone. This is the Goodsall's exception zone. Okay. Where it lies, the anterior region beyond 3 centimeters is the exception zone. Now, if we talk about the exception zone, yes, if the external opening is in the exception zone, then the opening will be in the posterior 6 o'clock position. So this should be our answer. Okay. Next option, anterior external opening within 3 centimeters. No, it will not open posteriorly. And ischiorectal abscess. Now, ischiorectal abscess, again non-specific. If there is ischiorectal abscess, we might get anal fistula, but again, that won't mean that it will always open posteriorly. But remember the fact that the most common location is actually posteriorly. So, had option B been not there in our option D would have been correct. Okay. So, Goodsall's rule is clear. Moving on to the next question. A 38-year-old man presents with a chronic discharging perianal sinus and recurrent perianal pain. Right? So, MRI of the image is shown over here. We can find a fistula. The sinus is converted into a fistula. Okay. Which of the following statements about the diagnosis is false? The diagnosis is nothing but our fistula in ano. Right. Let's read the options. MRI is superior to endoluminal USG in detecting internal opening. This is a false statement. Remember that endoluminal USG is the best choice to determine the location of internal opening. It is a better choice as compared to MRI. Okay. Associated with Crohn's disease, yes, it is associated with Crohn's disease. Associated with Watercan perineum. Now, what is Watercan perineum? Watercan perineum is nothing but a complex fistula. It is nothing but a complex fistula with multiple openings. This is our Watercan perineum. So yes, it can be associated with Watercan perineum. Although the MRI doesn't point out to be a doesn't show this to be a water can perineum, but yes, fistulas can also cause water can perineum. May be associated with anorectal abscess. Yes, this is one of the most common causes of fistula. Okay, so over here our answer should be A. Moving on to the next question. Which statements are true regarding Goodsall's rule? We just read about it, right? Posterior openings follow curved tract. Yes. Anterior openings within 3 cm follow straight radial tract. That's also a true statement. Anterior openings more than 3 cm behave like posterior. That's also a true statement. Not applicable in Crohn's fistula. This is also true. Remember that Goodsall's rule. What are the exceptions? What are the exceptions to Goodsall's rule? Number 1 are secondary causes. Secondary causes are exceptions. What are the secondary causes? Secondary causes can be Crohn's disease, can be tuberculosis, can be due to rectal malignancy, can be due to rectal malignancy, can be due to radiation induced, can be due to radiation induced fistulas, can be radiation induced fistulas, right? Besides that, even multiple fistulas, when a patient has multiple fistulas, they also do not follow Goodsall's rule. These are the exceptions to Goodsall's rule. Okay. So over here answer would be D. Again an INICET question. Moving on to the next question. Match the following with respect to the management of fistula in ano. Right. Something that we need to know regarding the management of fistula in ano. Regarding the management of fistula in ano, it is divided into two categories, two broad categories. Right. Number 1 are the low-lying perianal fistula. Number 2 is high-lying. For low-lying, we have two options. We can go for fistulotomy or fistulectomy. Right, fistulotomy is nothing but opening the tract, whereas fistulectomy is nothing but removing or surgical excision of the tract. Okay. And for high, we go for sit-on placement. What is sit-on placement? We actually pass a thread through the fistula. A thread is passed through fistula. Thread is passed via fistula, and we tighten it, right? And when we tighten it, it will slowly cut and heal through the fistula. That will lead to complete healing or fibrosis of the fistula tract. So that will lead to cut and healing of our fistula, thereby curing it. Okay. Now let's have a look into the table. For low perianal fistula, we just read, for low perianal fistula, we would go for fistulotomy. For high perianal fistula, we would go for sit-on placement. Lowest risk of incontinence is actually seen in lift procedure. What is lift? Lift is nothing but ligation of fistula's tract. Over here, it is, we just remember the fact that lift is a sphincter saving procedure. Since it is a sphincter saving procedure, so it will decrease the risk of incontinence. And remember that anal incontinence is the most common complication of surgery right? Okay. If we go for fistulectomy, it does increase the risk of incontinence. And highest recurrence rate is seen with fibrin glue. So our answer would be A1, B3, C2, D4. A1, B3, C2, D4. Option B should be our correct answer. Okay. Moving on to the next question. Indications for sit-on placement. High transsphincteric fistula. For higher fistula, sit-on is the best choice. Okay. Crohn's associated fistula, yes. Remember that sit-ons can be of two types. It can be a cutting sit-on. It can be a draining sit-on. A cutting sit-on is used when the inflammatory component is absent, whereas the draining sit-on is used when inflammatory component is present, like Crohn's disease, like tuberculosis. Okay. So yes, even for acute infection and fistula, we would be using a draining sit-on. So yes, sit-on is used in acute infection plus fistula. Intersphincteric fistula. Remember that intersphincteric fistula was the low-lying fistula. It's a low-lying fistula. So the treatment of choice in a low perianal fistula is not sit-on placement. It is fistulotomy or fistulectomy. So our answer would be A, B and C. Option B should be our answer. Another INICET question. Okay. Moving on to the next question. Best treatment for Crohn's fistula. Right? It is without doubt sit-on drainage plus biologics, infliximab for underlying Crohn's disease. Why not fistulotomy? Because it is associated with poor healing. poor healing. Cutting sit-on, no, it is not used because the inflammatory component is present in Crohn's disease. And fibrin plug is not used because of very high chance of recurrence. Okay. Moving on to the next question. Most common complications or complication of fistulotomy, right? As we have already discussed, it is anal incontinence. Why is it so? Because in fistulotomy there is division of at least a part of our internal sphincter. Right? There is division of our internal sphincter which leads to incontinence. Okay. Moving on to the next question. Now the risk factors for post-operative recurrence. Missed internal opening. Yes, this is rather the most important factor. This is rather the most important factor responsible for recurrence. Okay. Horseshoe extensions. Now horseshoe extensions depict complex anatomy. Remember that any complex anatomy increases the risk of recurrence in case of fistulas. Okay. Horseshoe extensions are nothing but complex anatomy. Crohn's disease again is a part of complex anatomy, falls under complex anatomy, because in Crohn's disease we see branching, right? An incomplete tract excision, of course, this is also a risk factor where we get persistent fistula. Persistent fistula is also a risk factor for recurrence. So our answer would be D, all of them. Okay. Moving on to the next question. An MRI shows a fistula tract originating from the rectum above the dentate line, piercing levator ani and exiting the buttock. Now from the given information, the tract is piercing the levator ani and is opening above the dentate line, so it is an extra sphincteric fistula. The few things, okay, what is the best management? Now important things that we know about extra sphincteric fistula is that number one, it is a high lying perianal fistula, and another thing that we know is that it is almost always due to a secondary cause. Okay. Now fistulotomy and fistulectomy are directly ruled out because they are the preferred one for low lying perianal fistula. Right. Now sit-on only, yes, sit-ons are the preferred treatment for high-lying fistulas, but sit-on only, this only word makes it an incorrect statement, right? Because extra sphincteric fistula are due to secondary causes. Sit-ons can be used as a temporary measure, draining sit-ons, but the best answer would be, of course, correcting the source pathology and staged repair. Okay. So with this, we come to the end of our discussion on perianal fistulas. If you like this video, consider subscribing to my channel, and thank you for watching.